Muscles associated with the face tend to fall into one of two categories. Muscles of mastication are muscles innervated by the mandibular division of the trigeminal nerve and will be discussed in a later slide. Second are muscles of facial expression. Muscles of facial expression are cutaneous muscles which are firmly attached to the underside of the skin. Contraction of these muscles moves the skin and allows for facial expression. All but one of the muscles of facial expression are innervated by the seventh cranial nerve, the facial nerve. Associated with the forehead is the frontalis muscle. This muscle allows us to wrinkle our foreheads. The frontalis is connected to another muscle called the occipitalis via an aponeurosis. The frontalis, aponeurosis, and occipitalis muscles collectively are known as the epicranius. Muscles associated with the eye include orbicularis oculi. This allows us to open and close our eye. The corrugator supercilii, seen here as the corrugator muscle, it allows us to elevate and wrinkle our eyebrow. Last but not least is the levator palpebrae superioris. This attaches to our upper eyelid and also helps us to keep our eyes open. The levator palpebrae superioris is the exception to the facial nerve, as it is innervated by the oculomotor nerve, or the third cranial nerve. Muscles associated with the nose include the procerus, which is a muscle located at the superior part of the nose, or at just above the bridge of the nose. The procerus allows us to create a wedge between our eyebrows. The nasalis is associated with flaring of the nostrils and helps us to keep our airway open through the nose. Muscles associated with the mouth allow for speech, feeding, and expression such as smiling and frowning. Muscles that elevate the lip include the levator labii superioris, the levator labii superioris aliquae nasi, and the zygomaticus minor. All elevate the upper lip. Muscles that elevate the corner of the lip and assist in smiling include the zygomaticus major and the levator anguli oris. Muscles that depress the corner of the lip, as in a frown, include the depressor anguli oris. Muscles that depress the lower lip are the depressor labii inferioris, and our pouting muscle between the depressor labii inferioris are the mentalis muscles. The risorius allows us to grin from ear to ear by laterally drawing the corners of the mouth towards the ears. And then there's the orbicularis oris. The orbicularis oris allows us to pucker, as when we whistle, drink a Slurpee, or eat a long spaghetti noodle. Within the cheek, we find the buccinator. The buccinator allows us to blow out candles. It also helps us to force food centrally during mastication. Last, there is the platysma. The platysma is a broad muscle in the neck that attaches to the inferior ramus of the mandible. It likely allows us to depress the mandible. based upon its location of attachment. These are the muscles of the face. They are all innervated by the branches of the facial nerve or cranial nerve 7, with the exception of the levator palpebrae superioris, which elevates the eyelid. That is innervated by cranial nerve 3, or the oculomotor nerve. The nerve that innervates or provides motor innervation to all but one of the muscles of facial expression is the facial nerve. It is the branches off of the facial nerve that innervate these muscles of facial expression. The facial nerve exits via the stylomastoid foramen. It has a posterior branch that is the posterior auricular nerve. It is the posterior auricular nerve that innervates the stylohyoid and the posterior digastric muscles. Its anterior branches include the temporal branch that innervates the temporalis muscle, as well as the upper part of the orbicularis oculi, the zygomatic branch that runs along the zygomatic arch, innervating the lower part of the orbicularis oculi, as well as the zygomatic major and minor, the buccal branch that innervates the buccinator and likely the risorius, the mandibular branch that innervates the depressors of the lip as well as the mentalis muscle, and then the cervical branch that innervates the platysma. The facial nerve courses through a gland known as the parotid gland within what is known as the parotid region of the face. The parotid gland sits right here, such that anything that affects the parotid gland, such as mumps, can cause facial paralysis. Bell's palsy is another disease that attacks and affects superficial nerves. One of the most clinically important examples has to do with the involvement of the zygomatic branch of the facial. The zygomatic branch innervates the lower part of the orbicularis oculi. Weakness or paralysis of the lower part of the orbicularis oculi will not allow your patient to shut their eye. This will result in drying of the cornea, result in itching, and if your patient's mental status does not allow them to regulate how much they itch their eye, they can abrade their cornea, cause infection, and potentially it could lead to blindness. Patients that have facial paralysis that involve the zygomatic branch of the facial or involve the orbicularis oculi should be provided a patch and a way to irrigate the eye in such a way that the cornea can be preserved. The next region is another region within the temporal region, and that is the region of the TMJ. The temporomandibular joint is a joint formed between the condyle of the mandible and the mandibular fossa of the temporal bone. The temporomandibular joint is a synovial joint. It has a biconcave disc associated with it. That biconcave disc is made up of fibrocartilage. Anteriorly, the disc is attached to the lateral pterygoid. When the jaw opens, the lateral pterygoid will pull on the disc, and as the mandibular condyle moves anteriorly, the biconcave disc should move anteriorly with it. Structures within the strata of the capsule will then prevent the disc from moving too far forward, as well as elastically bringing the disc back into the position during closing of the jaw. Here is an artistic rendering of the temporomandibular joint. Here is the mandibular condyle. Here is the mandibular fossa. Attaching to the anterior part of the disc is the lateral pterygoid. Attaching to the posterior disc is an inferior and superior stratum. The inferior stratum is made up of type 1 collagen and serves as an anchor to the disc. It's synonymous with a boat being tied to a dock. That tie to the dock will allow some movement of the boat while not allowing the boat to get too far away from the dock. So the inferior stratum really prevents the disc from going too far forward. The superior stratum is an elastic tissue such that during closing of the mouth, the elasticity of the superior stratum will draw the disc back into the joint space along with the mandibular condyle. Issues with the inferior or superior stratum, or tightnesses or weaknesses within the lateral pterygoid, can cause clicking or even can cause the jaw to get stuck on the disc. There are 4 muscles that are considered muscles of mastication. The temporalis is a muscle that connects from the temporal bone onto the cornoid process of the mandible. The temporalis, when contracting, causes retrusion and closing of the jaw. The masseter connects to the external ramus of the mandible. When it contracts, it closes and protracts the jaw, or protruses the jaw. Running along the ramus of the mandible interiorly is the medial pterygoid. The medial pterygoid also closes and protracts the jaw. The medial pterygoid and the masseter envelope, if you will, the ramus of the mandible. The lateral pterygoid attaches to the anterior part of the disc, draws the disc of the TMJ forward during opening of the jaw. It also eccentrically contracts, controlling disc moving back during closing. In addition, it has the ability to depress the mandible as well as protract the mandible. Lateral movement of the jaw is a synchronous combination of both protraction on the opposite side and retraction on the same side of movement. So to move the jaw to the right, your temporalis would retract on the right, while your masseter medial, and lateral pterygoid would protract on the left. Movement of the jaw to the left would require retraction of the temporalis on the left and protraction of the masseter, medial, and lateral pterygoid on the right. So once again, lateral movement requires retraction on the same side by the temporalis and protraction on the opposite side by the masseter, medial, or lateral pterygoid. All of the muscles of mastication are innervated by the mandibular division of the trigeminal nerve, which will be discussed in a future slide. Dislocation of the TMJ can occur with auto accidents, sports injuries like sandlot football, for example, fighting, whether that be organized junior karate class or I'll meet you at the bike racks after class type of fighting. Unfortunately, this is a fairly common area of dislocation. Depending on the direction of dislocation, other structures may be involved. A lateral dislocation of the temporomandibular joint will affect the temporal branch of the facial nerve. A medial dislocation of the temporomandibular joint will affect the middle meningeal artery as well as the third portion of the trigeminal nerve, the mandibular portion. This mandibular portion will include another nerve known as the chorda tympani, which is a branch off the facial that has taste from the anterior 2/3 of the tongue. Last, a posterior dislocation will affect the root of the facial nerve as well as the auriculotemporal nerve.